Hello.
Hello, Dr. Szabo. How are you?
Oh, hi. Are you Doug?
Yes, I am.
Nice meeting you. Do you want to have the video sharing at all, Doug?
Well, I think I've given you the ability to share, but I would have to stop sharing.
Oh, no. I would say, I think, do you want video or just voice is good enough, Doug?
It's up to you whether you want to do video. I'm not sure if you see me.
Oh, I can see you.
Okay.
Yeah.
And here's Jim.
Hi, Jim. Is Mary?
How are you, Mary?
I'm good.
Thank you very much for accepting to talk to our people.
Oh, absolutely no problem. I think last year I gave similar kind of stuff up in Edmonton. So, yeah. Now, the only thing is I need to sort of say how to, okay, now you can see me.
All right.
Yes.
Good. All right. So I am new to Zoom, and of course, I'm an idiot for these kind of stuff. So I think that after you introduce me, I would share my screen then. How's that?
Okay.
Good.
Okay, because then it will not kick you out. So.
Yeah. Well, I'll stop sharing and then you can share.
Sure.
When you stop sharing, then I'll share. Yeah.
Okay, good. And I guess the question will come through for audio, right?
Yeah, you can mute yourself if you want. I think I can do it too, but I'm new to this as well. So
We got a lot of new people doing this.
You know what? COVID-19 certainly make us learn how these technical stuff, isn't it?
Mm-hmm.
It sure does.
Yeah.
Well, that's good. We've got 5 attendees so far.
Oh, good. So how are you guys doing?
Well, we're doing good. We're spending a lot of time on Zoom.
Oh, yeah? So you guys are expert in it?
No. We're just spending lots of time on it.
Yeah. So.
It's become certainly a valuable tool.
Yeah,
but
It actually changes the way we practice too. In the beginning, we do a lot of video conference.
right.
So we actually sent, that was before Zoom, we actually sent people Microsoft Team and we can do a lot of stuff on video. But since then, the office is pretty safe, so they are able to actually come in, but we still do quite a bit by virtual medicine. So,
And just so everybody
Yeah.
knows, as attendees join, they will be able to hear this conversation.
okay,
Oh, okay. So we better not say
say
anything.
anything.
So,
So I'm going to mute until you start, okay, Doug?
Sure. Is that you, Jim?
what's that sound anyways?
It's testing of our fire alarm in the office.
Oh, whoa.
Yeah. They promised me we'll stop in 15 minutes.
So Jim, what do you see? Do you see the CARP?
I see the
presentation?
slides.
Okay, and do you see just the three of us on the side then?
Right.
Okay, that's all you see.
Okay.
Okay.
Okay. Okay. Okay, so it's just 10 o'clock now. I think we should give it another couple of minutes just to see, because people are still coming in. Yes. Yeah. Good idea.
So to everybody who's attending, I am monitoring the chat function. If you have questions during the presentation, general questions, you can post them through the chat, or we will be using the Q&A function, which we'll get into later. Dr. Szabo, is it okay if I mute you until your time?
Absolutely.
Okay. Okay, we'll just wait one more minute.
All right.
Okay, well, I think we can start. I'd like to welcome everybody to CARP Calgary's first webinar. This is how we're doing things now with the pandemic. So hopefully we won't have too many technical difficulties. So I'm just going to start the presentation. So today's agenda is we will get a message from the president of CARP Calgary. Then I'll be giving a message on one of our advocacy campaigns about seniors advocates. Then we'll hear from Dr. Mary Szabo from the flu vaccine. Then we'll hear from Mile Stanijic, which is the medical science liaison for Sanofi, Western Canada, which is actually a vaccine producer. Then we'll open it up for questions. So at any point in time during the presentation, if you'd like to use the Q&A function of the Zoom application or the Zoom website to ask questions, and they'll be saved and I will read them out at the end of the presentation. So now I'll turn it over to Jim, who's our president of CARP Calgary.
Thank you, Doug. Welcome and thank you for joining us this morning. Sadly, we can't shake hands or hug you, but we greatly appreciate the fact that you're joining us for this very valuable and informative session on vaccines. We have two super presenters, and before introducing the speakers, I'm going to turn it back to Doug so that he can tell you about our advocacy project that we have, which is trying to, I'm going to say, trying to get a seniors advocate appointed to the legislature. So Doug, I turn it back to you.
Okay, thanks, Jim. So I'm not sure how many people know that Alberta did have a seniors advocate from 2016 to 2019. They were put in place by what's called a ministerial order, where most advocates are put in through legislation. So the fact that it was put in through ministerial order means that it could be revoked at any time, and that's exactly what happened. So the advocate's office wasn't renewed, and it's now part of the responsibility of the Health Advocate of Alberta. We believe that Albertans deserve a dedicated seniors advocate office, and I'll tell you a little bit more about that in the next slide. And just so people are aware, Alberta has 7 other advocate offices. Some are health related, such as the Health Advocate There's one for mental health, there's one for children, there's one for people with disabilities, and then there's a few others that aren't really health related. CARP Calgary is working with other seniors organizations in Alberta to gain support for an eventual proposal to the government. So we are talking to seniors organizations in Calgary, Edmonton, Lethbridge, Red Deer, Fort McMurray, trying to make sure that we're all aligned and we have support from more than just CARP Calgary for the seniors advocate to be reinstated. And we'll tell you more about how you can help on this advocacy campaign in the coming few weeks. So what we're looking for out of a seniors advocate is to represent the rights, interests, and viewpoints of seniors. So the primary functions of the advocate, first of all, is to resolve issues of individual seniors that can't get what they need out of the system. The next points really refer to what they do at a systemic or whole program related perspective. So reviewing programs and policies affecting seniors, participate in consultations when systemic decisions are made, such as stuff about ageism, long-term care, that kind of thing. Provide information to the government on this. Deliver public education that promotes rights, interests, and well-being of seniors. While the Seniors Advocate was in place in Alberta, they gave some 65 presentations to different organizations. So this also is the education part, that individuals having difficulty accessing programs and services are aware of the appropriate resources, persons, and organizations. So Jim, I'll turn it over to you and we'll get started with the presentation.
Thanks again, Doug. It's my privilege to introduce Dr. Mary Szabo, who is a family physician and clinical associate professor. Dr. Szabo has been in practice in family and emergency medicine for over 35 years. She has extensive experience in both emergency medicine and family medicine, both internationally and nationally. She's practiced medicine in a number of countries around the world, including, and you have to look this up, one tiny island of Rhoda near Guam in the Pacific. Also the Kingdom of Saudi Arabia, Abu Dhabi, and nationally here, Alberta and Ontario. Dr. Szabo has also proudly served in the Canadian Armed Forces as a medical officer holding the rank of captain. She's currently a clinical associate professor with the Department of Family Medicine at the University of Calgary, where she loves to teach, saying that teaching helps challenge her and keep her medical knowledge up to date in our constant evolving medical world. And certainly we are in a medical evolving world. And I turn it over to Dr. Mary Szabo, and thank you very much.
Thank you very much, Jim. I'm going to try to share my screen, and hopefully my slide will show up. Are you guys okay?
Yeah.
Okay. Okay, can you see my slides?
Yes, we can.
Okay, so thank you very much, Jim, for the very nice introduction, and good morning to everybody. So as you know, winter is coming and the flu season is just around the corner. And this year with COVID-19 pandemic is still unfolding, and there is evidence that Canada is actually entering into the second wave of the pandemic, that this flu season is not like other previous season. And public health official actually is now very concerned about the possibility of a trendemic. What it means that is to have two viruses causing disease at the same time. So this can actually greatly impact our senior. So this presentation, I would likely to quickly go over overview on influenza as well as COVID-19 and discuss the burden of both disease for our senior and explaining why seniors are more vulnerable for these kind of disease and the impact of this influenza season on our senior. So what is influenza? So influenza is actually a highly contagious respiratory disease which comes to haunt us every single year. And there are 3 strains of influenza, A, B, and C. However, it's the only human influenza type A and B causes the seasonal epidemic. Otherwise, type C is so mild that they are not thought to have any kind of problems at all. So these are the influenza facts. They are not as benign. Globally, there is about 1 billion cases of flu. And out of that, 3 to 5 million cases are severe flu related, which might need hospitalization. And globally, we have around 300,000 to 600,000 flu-related deaths. Now in Canada, there is about 40,000 laboratory confirmed cases. However, this number is markedly underestimated because a lot of people with influenza doesn't seek medical help or being tested for the disease. And nationally, flu-related hospitalization is about 12,000. And flu-related emergency visits is about 175,000. And flu-related deaths on the average for Canada is about 3,500 people per year. So Mile is going to touch on the symptoms and severity and everything on influenza, but I want to quickly touch on influenza. Besides giving us symptoms, they also causes direct and indirect complication. With the direct effect, it's mainly with the respiratory system that you can see that the flu can cause us exacerbation or worsening of your underlying lung conditions such as asthma and such as chronic obstructive lung disease. It can also causes you to have an ear sinus infection, and it also causes you to have bronchitis and pneumonia. Now, indirectly, which is not related to the respiratory system, the flu can actually trigger off a heart attack and also a stroke, and it causes your pre-existing cardiac or heart problem to get worse, such as increasing heart failure. And if you have chronic kidney disease or diabetes, influenza tends to actually exacerbate these chronic disease and actually makes it worse. So for the fact that for us senior who are 65 and over, even though we account for about 15 to 17% of the Canadian population, however, we are accounted for about 70% of the flu-related hospitalization and 91% of the influenza-related deaths. So you can see that the disease burden of influenza on the senior is quite impressive. The next slide I show is really summarize that influenza is really underappreciated by a lot of people. So as you can see that the number of lab confirmed cases of influenza is just the tip of the iceberg. Many of the people who's being infected with influenza are actually not, they don't seek medical advice or else they don't get tested. So the true infective rate is far more than what is being recorded as 40,000 per year. The other problem is, the perception of influenza as a very minor and a nuisance disease with symptoms such as a cough, headache, muscle aches, and pain, which generally resolve in about 7 to 10 days. However, The bottom part below the horizon, especially for us senior, is the flu can trigger off the heart attack and the stroke. It can cause both either viral or bacteria pneumonia. It can aggravate your chronic disease, and it can make your diabetes and asthma and chronic disease a lot worse, and even death. So it is true that the medical and economic society burden of influenza is really underappreciated. So I would like to talk a little bit about coronavirus because it is important. So the coronavirus is just like the influenza, is a very highly contagious respiratory disease. So it is caused by the SARS coronavirus type 2 viruses. And the WHO declared COVID-19 as a pandemic in about March of 2020. And to date, when I look at the newest data from what happened globally, is we have about 30 million people who has been confirmed to have COVID-19, and more than 1 million COVID-19 related deaths. Now, the interesting thing is, just like the influenza, the number of 35 million is most likely underestimated, because many cases for coronavirus COVID-19 are very mild, or people are actually asymptomatic. So they are not being tested. And many countries, the testing capacity is actually low. So the true infective rate of COVID-19 is actually underestimated. So it is a zoonotic origin, meaning that it is originally from animals. And the virus itself is closely linked to two strains of viruses, which is found in bats. So a lot of specialists believe that it started from the bat and jumped species to human being, and then it's transferred. I'm going to leave the transmission to Miles because I know that he will go through that. So just like influenza, COVID-19 can cause very mild disease, and 80% of the cases are very mild. However, the severe disease and the critical disease, severe disease which causes hospitalization, the critical disease which causes admission to the intensive care, the senior population carry a very high burden of that. So who gets COVID-19? As you can see from the slides, that anybody can get it. But as it is now, people under 60 account for about 70% of the confirmed cases. And it has been shown that, people younger than 40 years old are the main driver for the community transmission. So what's a disease burden for COVID-19? And you can see from this slide that this is hospitalization, and you can see that about 70% of the COVID-19 related hospitalization are in the senior 65 and over. This number is fairly similar to the flu. And the next slide shows deaths. And again, you can see that the disease burden falls on the senior, and senior accounted for about 96% of the COVID-19 related deaths. So this slide is taken from CDC, and if you pay attention to the age group in which they compare, if they're younger than 18, the chance of getting hospitalized for COVID-19 is lower, both in hospitalization and deaths. However, as you increases in age, and by the time you are about 65, that risk increases dramatically with COVID-19 related hospitalization and as well as death. And by the time you're 85 and over, you are about 360 times more probable to die from the disease. So the upper number the upper bar just shows that what are the factors which causes community transmission. Very crowded condition, you don't have social distancing, you're in an enclosed space, and the duration of exposure to someone with COVID-19. And one of the ways that we can actually prevent it is actually wear a mask. Maintain your social distancing, frequent hand washing, always sanitize. So this slide is taken from actually CDC. I will draw your attention, these are American data. And when the time I prepared this slide, there was about 191 cases of COVID-related death. And these are the co-medical morbidity. Almost 50% have a medical respiratory comorbidity, in particular influenza and pneumonia. And you can see the number of cases increases as you increase age. So why are we seniors so vulnerable to infectious disease, influenza or COVID-19 or pneumonia? It's because when we grow older and smarter and wiser, it leads our immune system is weakened, and this process is called immunosenescence. So this will predispose us to more severe infection and also reduces our ability to protect ourselves when given the vaccine, the ordinary vaccine. And in particular, the influenza, there is a high-dose flu vaccine, which is particularly designed to address this immunosenescence to make sure that the response is good. Second thing is the prevalence of medical condition will increase as we get older. So about 50% of the people who are 65 and over will have at least one medical condition. As you increases in your age, by the time that you get to about 70 years old, about greater than 80% of us will have at least one medical condition, if not more. And as we grow older, we become more fragile. And that will make us into a very vulnerable population and expose our infection and causes complication with hospitalization. And when seniors are discharged from hospitalization, they have a long road to recovery. And some of them never recover to pre-hospitalization, and they have to actually enter into assisted living or nursing home. And the worst of all is it can increases the mortality related to these kind of disease. So the impact of influenza during the pandemic is this. We are high risk for severe and complication for both disease. The risk of co-infection is real, and it really affects our well-being. And we carry a high disease burden for both disease. Bear in mind that there is no approved treatment or vaccine for COVID-19. However, there is approved prophylaxis, post-exposure prophylaxis, as well as a valid flu vaccine for the senior to reduce our risk. So what is the summary? And the key point to take home is we seniors are a high-risk population for severe and the complication for both nasty disease. We carry a high disease burdens for both disease. Co-infection is disastrous for us, and a flu shot for yourself, your loved ones, and whoever cares for you will help to reduce your risk of having influenza during this flu season. And as I say and highlight in blue, this might be your most important flu shot this year. Thank you. And any question?
Yeah, I guess we can handle questions for Dr. Szabo at this point in time. We've got just a couple. The first one, is it possible that COVID is a reoccurring illness? It was asked, one question.
It's actually a possibility because the virus, since it emerges from China in December, there are signs that COVID-19 virus or the SARS coronavirus 2 has had some mutation, which has occurred. So there is a possibility that it can recur. But COVID-19 is such a new disease that we will just have to wait and see what the data will come back in terms of mutation. So yes, there is a possibility.
Okay. Another question, couple of questions around high-dose flu shots. One person said that they had this in previous years in Edmonton and have been told not available in Calgary unless I want to pay for it at a private clinic.
That is true. In some provinces across Canada, high-dose flu vaccine is covered for people 65 and over, especially in Ontario. Now, in Alberta, I was being informed that if you're in a long-term care facilities, which are publicly funded, or if there is an extended care which is tied to that publicly funded long-term care, then the government will cover the cost of the high-dose flu zone. But for most of the community senior, it is true that the government do not cover, and you have to pay out of pocket. And that's something in which I hope CARP member will actually, how would I say, lobby the government to have them covered for anybody who's 65 and over, because it really saves life and it reduces the burden on the medical health system. So it's yes and no, but if you don't stay in the long-term care, which is public funded, or in an extended area, lodging, which is tied to the long-term care, you will have to pay out of pocket for the vaccine.
Okay. Another question around the flu shot says, which is 3 or that with 4 types. I think there was something how there's only 2 strains in the normal flu shot and 4 strains in the high dose, or can you explain that one?
Sure. So what's available in Canada right now, there are the standard dose and the high dose. And the only difference between those flu shots is the amount of antigen, okay, in the 2 vaccine. You remember in my previous slide, I say that because as we grow older, our immune system is weakened. So the response to the standard dose is not as good as the high dose. So the difference between the standard dose and the high dose is the high dose contains 4 times as much antigen in order to kick our immune system in the teeth so that they will respond. But as far as the number of strain which is covered is identical. So what is available in Canada right now is whether it's the standard dose or the high dose contain 3 strain of influenza virus. It will contain 2 strain of influenza A and 1 strain of influenza B, okay? And this strain is changed, I know for a fact that this year they have 1 strain which is cover H1N1, and the other one is H3N2, which is very important for the elderly, causes a lot of mortality and morbidity. And so next year, I was being told that hopefully we'll have 4 strain, which will cover 2As and 2B, but this year in Canada is not available, but hopefully next year. Does that answer the question?
I think it should. Just 2 other questions so far. So does the annual flu shot cover any influence or preventing or minimizing the impact of COVID-19?
Yes and no, in a sense, is that Miles would talk to you guys about clinical presentation, because the 2 clinical presentation is extremely similar. So it's very difficult to tell whether you have the flu or you have COVID-19. Both can affect us. So if you get immunized against the flu shot, that will actually reduces your risk of having a co-infection, meaning that you will have influenza plus COVID-19. So you will not overwhelm your immune system just in case if you get COVID-19. Your immune system will be hopefully strong enough to handle the COVID-19 infection.
Okay, there's still a few more questions, but what I think we should do is go to the second part of the presentation.
Sure.
And Jim, I'll let you do the introductions.
Yeah. The one thing is, because I have patient book, I might have to leave the meeting early. So I'll be more than happy to answer any of the question if I have to leave, because my next patient is booked at 11 a.m.
Okay, thank you very much.
Thanks, Dr. Szabo. That was great. I know that just brings up a lot more questions And in today's world, there's lots of concerns and stresses with people on influenza and especially with COVID. So again, I thank you very much for your participation. Now it's my pleasure to introduce Dr. Mile Stanjic. Dr. Stanjic completed his PhD training at the University of Toronto. We're not going to hold that against you, by the way, with a degree in medical science specializing in immunology. He was previously a member of the Surgical Infection and Shock Society and has published extensively on the acute phase inflammatory response to thermal injury, the impact of trauma on older adults, and mediators of inflammation. Presently, Mile is a medical science liaison with Sanofi Pasteur Canada for the Western provinces, providing medical education and external support. So he's here today with his medical education for us and his support. We've talked to Dr. Stanjic before, and so Mile, I turn it over to you.
Thank you very much, Jim, for that warm introduction. And I'd like to thank everyone for attending today's seminar and for allowing me the opportunity to present. As we just received a comprehensive overview from Dr. Szabo, I wanted to then continue the conversation and really highlight the serious complications related to influenza, and of course, the updated National Advisory Committee on Immunization recommendations for this upcoming influenza season that we are on the eve on. So with that, next slide, please. Great, thank you. So just a quick disclaimer that the information that is being provided is of course reactive as per your request. And if we do happen to discuss any topics that are outside the approved indication, although I don't intend on, as an organization, I just want to highlight that of course we only recommend the use of our products consistent with that described on the product monograph. So next slide, please. The pandemic, which became known as the Spanish flu, is thought to have begun in the cramped and crowded army training camps, especially in the trenches along the French border. When the war ended in November 1918, and as these soldiers returned home, the Spanish flu, the influenza, was then able to spread globally, and the devastation that resulted was anywhere from 50 to 100 million individuals, unfortunately, losing their lives. And the reason that I bring this up, that although this pandemic was a century ago, you can see that we're finding ourselves in a very similar situation in this past year. So next slide, please. Now, in terms of the impact of vaccines in Canada, vaccination has dramatically reduced the morbidity and mortality rates for a number of diseases. The crucial element of vaccination programs is commitment to widespread coverage and the containment of outbreaks in Canada. So as you can see in these figures, due in part to the introduction of legislature for compulsory childhood vaccination in order for school attendance, this has supported the dramatic drop in incidence of these devastating diseases. Next slide, please. So now just to introduce COVID-19, or also known as SARS-CoV-2. So it is in fact a zoonotic virus, meaning that it is able to spread from animals to humans, and this is how the virus originated. It can be transmitted via droplets, and that is where the virus is released into respiratory secretions when an infected person coughs, sneezes, or talks onto another person in close proximity. Another form of transmission is indirectly, and this occurs when a person touches a common surface or a non-living object. So that would be, for example, if you were to go to a grocery store and an individual with COVID-19 coughed into their hand, they touched a doorknob or a door handle, you happen to touch that, and for whatever reason you had an itch, you poked your eye, and then now you have contracted COVID-19. So collectively, by understanding the mode of transmission of this pathogen, it allows us to appreciate the preventative measures currently being recommended by public health. Next slide, please. So when it comes to the initial clinical manifestations of COVID-19, there is no specific clinical features that differentiate it from other respiratory infections, including influenza. It typically causes mild to moderate upper respiratory tract illnesses with symptoms similar to the flu, such as fever, dry cough, tiredness, and in more severe cases, the infection can lead to pneumonia, kidney failure, and unfortunately even death. These severe cases are more common in populations with weaker or non-developed immune system, such as older adults, and also older adults or individuals with underlying conditions which render them immunocompromised. Next slide, please. So unlike influenza that currently has several antivirals and different types of vaccines that are available to help combat, the novel coronavirus or COVID-19 does not have an approved vaccine at this time. So at this time, we are limited to non-pharmacological therapies and preventative approaches. And I'm sure a lot of these you hear of in the news and in the media from our public health officials. And these include such preventative measures such as hand washing, respiratory hygiene, so coughing into your elbow, to avoid touching your face, to disinfect surfaces, physical distance, of course, to wear a mask and to stay home as much as possible to limit the transmission of the COVID-19. Next slide, please. Now, in terms of treatment or vaccines in development, this is what our current landscape looks like at this time. We have currently over 300 diagnostics that are currently in development. However, in terms of treatments at the center, what you will notice is that these have not worked out that well to date. And currently, what we really have available in terms of treatments is the repurposing of products or therapies that are licensed for other purposes. However, at this time, none have been dramatically effective. So this is why the focus and the attention has really been on vaccines and vaccine development. Now with that background, it brings us to our present day and where we are in terms of the eve of our annual fall influenza and respiratory virus season. And this year, unfortunately, will not be a typical season, as you can all imagine, because we have the complexity of the co-circulation of the SARS-CoV-2 virus. So without a vaccine, it is important now more than ever that everyone receives their flu shots in order to protect ourselves and also to protect our loved ones from serious complications and hospitalization. Next slide, please. So as medical professionals, we used to consider diseases as being communicable or non-communicable, with the two of them separate from one another. However, it's really until the last little period of time that we started to really appreciate and to realize that these are not separate islands, and in fact, they are intimately joined. In fact, lower respiratory infections are among the top 10 causes of death in upper middle income countries. Next slide, please. So I know Dr. Zaba already spoke to this, and I think if you want to click one more there, that'd be great, thank you. But there's also the direct respiratory complications related to influenza. However, I also want to briefly discuss and to consider that there is also indirect complications that occur. And these would be indirect, as the name implies, outside of the respiratory system. So this includes influenza's ability to increase your risk of heart attacks, stroke, and of course to exacerbate pre-existing conditions such as diabetes and renal disorder. Next slide, please. And one more click, sorry. Thank you. A classic example of this interplay or the relationship between influenza and myocardial infarction or heart attack has been studied extensively. And essentially, from our understanding, the stress that influenza causes on the body is able to trigger our immune system, and that robust response with millions of immune cells that are being produced to not only combat the flu virus or influenza, but it also results in exacerbation of underlying inflammatory processes such as atherosclerotic plaques. So with this inflammation, the atherosclerotic plaques in the heart muscle, heart arteries are able to break off and they're able to dislodge. And unfortunately, if they occur in the coronary arteries, which supply the blood to the heart, then this can result in a clot. And of course, a blockage or clot in our heart arteries is, of course, results in a heart attack. Next slide, please. The problem is We don't always uncover these relationships or associations until we investigate them in clinical studies. So studies like these are extremely important. And this one, for example, was conducted with public health data from Ontario. And what they found that influenza increases, if you have influenza, you are 6 times greater risk of having a myocardial infarction or heart attack within the 7 weeks after infection, relative to the week before or the week after. And in fact, when they stratified the data to look at specifically older adults, 65 years of age or older, that risk of heart attack after influenza increased to 7 times. So again, it's studies like these that are really important that we raise awareness to, because they expand our understanding of the relationship between influenza and non-communicable diseases. Next slide, please. There are also other studies that have shown to have, for individuals who have multiple pre-existing conditions, then what we can see is there is this cumulative or stacking effect that takes place. And in this particular study, they were able to look at influenza attributed death with individuals with pre-existing conditions. And what they found were individuals with chronic heart disease were at 5 times greater risk of influenza attributed death. If the individual had chronic lung disease, it was 12 times. And then if they had both chronic heart and lung, we have that stacking, 20 times greater risk of having influenza attributed death. Next slide, please. So now putting it all together, if we focus our attention on older adults, 65 years of age, aging, just the natural aging process leads to, first and foremost, the progressive weakening and the decline of immune function. And this process is termed immunosenescence, and it is associated with a decreased responsiveness of the immune system, placing them particularly vulnerable. Aging also leads to an increase in the prevalence or the likelihood of chronic underlying conditions. And of course, with naturally aging, there's of course the risk of frailty, which increases the risks of these individuals to have adverse outcomes and of course to have long-lasting disability and loss of independence. So all of these modifications combined, unfortunately, make older adults more vulnerable. And in fact, the National Advisory Committee on Immunization recognizes older adults as an at-risk group. Next slide, please. So I did, of course, emphasize the need and the importance of receiving your influenza vaccines. However, it's just not that simple. So previously we talked about the aging immune system, which results in that progressive weakness over time and its inability to respond as effectively. So as you can see on the top there, just say healthy adults versus older adults on the blue line at the bottom there, you see what's called this gap in effectiveness. And this means that over multiple seasons, a regular influenza vaccine is just not as protective and not creating the protection in an older adult relative to someone who is younger. Next slide, please. So when it comes to this upcoming influenza season, I just want to highlight the National Advisory Committee on Immunization's recommendations for this year. So for this season, they recommend that the trivalent high-dose influenza vaccine should be used over the standard dose. And this comes from the good evidence of better protection compared to the standard dose. NACI also does note on the individual level, which would be for yourselves, that it does not make comparative individual level recommendations between different types of influenza products, and in the absence of any one particular product, that really any influenza vaccine should be used to, of course, protect yourself. Now, in terms of, if you're asking, I know Dr. Zabel spoke to it, but what is high dose? So as she mentioned, it is recommended for older adults, and it was specifically designed for this vulnerable population that does not have the same responsiveness to the standard dose vaccine. It contains 4 times the amount of antigen for each of the 3 influenza strains that are located within the virus itself. And for this upcoming influenza season, it will be available to all older adults 65 years of age in Ontario and to all older adults 65 years of age in long-term care in all of the other provinces and territories. So next slide, please. I'm just going to summarize here. So as we face these uncertain times of COVID-19, it is important now more than ever that we take the preventative measures to ensure the safety for ourselves and also for our loved ones, and of course, for our greater community as a whole. And as we prepare for the imminent influenza season, we need to continue to educate and to raise awareness and advocate for increasing immunization rates, but also to continue to protect ourselves and ensure that the most vulnerable older adult population is receiving the best possible vaccine in order to protect against influenza morbidity and mortality. And with that, I would like to thank you all for attending and of course for allowing me to present, and I'd be happy to answer any questions at this time. Sorry, I don't hear you there, Doug.
Can't hear you, Doug. You got your.
Okay, there we go. I did this before. So we do have a few questions.
Sure.
Where is the first one? And I'm not sure what they're meaning by this one, but somebody asked, is there an antidote for the yearly flu vaccine? So I'm not sure if what they're actually asking there.
I'm not quite sure.
So if that person can restate the
Perhaps,
question.
yeah, if you could perhaps clarify, and then I think I know what you're asking, but if you clarify, I could probably best answer your question.
Okay. Another question is, while your body is dealing with the flu vaccine, are you not more susceptible to COVID-19?
So that is a great question. And of course, as I mentioned, it places your body at risk. You're creating that robust immune response, and your body is vulnerable to obviously the stress. However, at this time, that's difficult to answer because there is no good literature out there to specifically state that if you have influenza, then you are more likely to have COVID-19. However, in general, as I mentioned, with that robust immune response, your body is vulnerable during that period of time.
Okay, and there was a question about being new to Calgary. So where specifically do we access the high dose flu shot? And what are the private clinics referred to? And then somebody else shared a link to albertahealthservices.ca/influenza/influenza.aspx. And you see all the flu shots in Calgary. So if Dr. Szabo, if you want to answer, confirm that.
Yes, I think there are a number of places who can carry the high dose flu shots. Some of them are the pharmacy, and because the government does not actually pay for the flu shot in the long-term care or extended care tied to a public funder, you have to pay for it. So what we do for our patients in our clinic is we purchase X number of doses of high-dose flu shot, Fluzone, and we give it to our patient at a cost. And the cost is basically what we buy what it costs for us to actually pay for the vaccine itself, as well as the injection fee. So now it varied from places to places. There's some pharmacy, like the Safeway Pharmacy, they will carry some high dose, but there will be a charge for that. And that charge varied according to the pharmacy. So ask your family doctor office whether they carry that, or else ask the pharmacy whether they carry it. But there is a charge for the high dose, but there's no charge for the standard dose.
Okay. Another question is it advisable to get both the low dose and the high dose flu vaccine?
That's a great question. And I do notice that it does come up frequently. I know last year there were some delays in terms of the availability of high dose. So it was a common question. At the end of the day, there is no literature and there is no evidence to suggest that by taking two of them, you're going to have an added level of protection. Of course, we recommend just taking one. And of course, the one that's going to provide you with the best possible protection. But also just keep in mind that anything that you were to put into your arm, if you do have any potential redness or swelling or pain, you're exposing yourself to two of those pokes. So of course, you just want to avoid that and just give yourself the one and the best possible vaccine to give you the best protection.
Okay. Person said, I'm 61 years old, so would it be worthwhile to get high dose?
So that's a great question. So of course, high dose, as I mentioned, is recommended for older adults, and it's authorized for the use in older adults 65 years of age or older. Because you are under 65 years of age, that's definitely a conversation that you'd want to have with your healthcare provider, whether it be your family doctor or possibly with your pharmacist.
Yeah. So said that they have underlying diabetes and high blood pressure, so I would imagine the doctor could easily prescribe that.
Yeah, so
And
that
I-
would be, sorry, go ahead, Dr. Zabo.
Yeah. Oh, I absolutely agree with Miles. I do use high-dose flu vaccine for people who are not quite 65, but have a lot of medical condition in which that they can compromise their health. And in cases like this, I do use the high-dose flu vaccine for those, what I call off-label reasons. So despite the monographs say that it should be 65 and over, but I have been using it for people who are younger than that, because really you cannot tell how immunocompromised it is, how the immunosenescence between a 62 years old or 65-year-old. The bottom line is they are immunosuppressed. And if they have other medical comorbidity, I explain it to our patient. We have a very nice chat of what is the benefit and what is the downside of receiving the high dose. So, in my practice, I basically would talk to these individuals and the benefits of it.
Okay, thank you. Another question, if someone just finished chemo treatment after cancer surgery, should they wait a while before having their flu shot?
So that's a great question. In that particular case, just given the circumstance, I would definitely recommend that that's another conversation that you would want to have with your clinician and perhaps even your oncologist to see if it's appropriate, given specifically your treatment course and your treatment journey that you're going through.
Okay. Another person asked, I'm going to summarize that, how did the Alberta government and I guess all the other provinces except Ontario make the decision that only long-term care are going to get the high dose for free and Alberta is not? Anybody?
To be honest with you, this is a very political question. If I have my way, I would really like to convince our provincial government and point to them the benefit and the cost saving to actually pay for everybody who's 65 and over. Bear in mind that the vaccine uptake is not 100%, and you will achieve, how would I say, herd immunity if 65% of the senior will be, receiving the high dose vaccine. But what the downside is, people have to pay money for it. So if anybody wants to convince a UCP by saying that it saves money and save budget, because it's a lot more money to actually hospitalize the individual when they're in the hospital. One of my patients got influenza, okay, and she was actually in the hospital for about 6 to 8 weeks. Okay, that cost alone will pay for many, many doses. And even then, it took her 3 years to actually go back to her pre-hospitalization state. And so, looking at the benefit and cost saving, I think we need to have a little chat with our government and convince them it is a good thing to do for our senior.
Okay.
Couldn't agree more. Thank you, Dr. Zabo.
I'm going to ask a couple more questions as we still have a few minutes here. One question, hypertension is listed as a risk factor. If you're being treated with an antihypertensive and are now normal tensive, are you still at greater risk, or is it just individuals perhaps underdiagnosed or undiagnosed and untreated hypertension?
That's a very interesting question. I think at the end of the day, also the age obviously plays a big role there, but at the end of the day, if you are over 65 years of age, for example, then you are considered, according to the National Advisory Committee on Immunization, you are considered an at-risk individual. Now, if you're coupling that with, for example, hypertension, whether it be currently or possibly in the past, then this would be contributing as an underlying premorbid condition. And again, it's just, again, contributing towards that and really just reinforcing that perhaps you are an at-risk individual. And so this is something, again, that you really want to have the conversation with your clinician. Whether it is managed or not, there is, of course, an underlying condition potentially that is reoccurring there, but it really comes down to your age.
And I agree with Mile. I mean, bear in mind that hypertension, it will put you at risk actually for COVID-19 infection as well. There's a lot of talk about the treatment making you susceptible to COVID-19, but the early data suggests that, people who suffer from hypertension or elevated blood pressure actually will increases your risk. So I basically will recommend them to be, number one, if they don't want to pay for the high dose, is to at least get the standard dose, and hopefully that would be enough to prevent or reduces the severity of influenza.
Okay. We have clarification on that earlier question, and it appears that the person reacted very badly to the flu vaccine. If the person says, well, if I'm taking pills over time, I can stop that, but once I get the vaccine, it's kind of in there. So do you have any comments about bad reactions to the vaccine?
So I see that fairly often in some individuals that they have a very bad local reaction to the vaccine. God didn't make us equally the same. Some people will react very badly, and in which the injection site is very, very painful and very, very red, and some of them is want to touch. And however, these are not infection. So there's no antidote to that, but when I see cases like this, I would actually treat them with local things like Benadryl, ice pack, and in a few days, those kind of adverse reaction will go away. The nasty, nasty adverse effect for vaccine is like Guillain-Barré syndrome, which is a neurological thing. That occurrence is extremely, extremely low. It's about 1 in a million cases. And so we don't see them that often, but if they do have them, then I usually don't give them the vaccine. But there's no antidote for the adverse effect, except that you actually treat them when they have the symptom. Miles, do you have anything to add to that?
No, I absolutely agree. And if depending on which vaccine, but for example, with high dose, the majority, and I think this would be more or less true for standard dose as well, the majority of any adverse events that could potentially occur usually are at the local site, whether it be redness or swelling, and they're more or less subside within a few days.
Okay, I'll ask a question just to add on to that. Vaccines used to be egg-based. Is that no longer the case?
So that's a great question. So the standard dose that's currently available, the quadrivalent in Alberta, is egg-based, and even the high dose is also egg-based. There are some newer technologies that some are available and some are currently in research and development that will be available in the coming years, and they use different approaches, whether they be cell-based, which means that they come from mammalian cells, so they're not coming from eggs themselves, they're not egg-derived, and other ones come from, for example, using recombinant and different technology platforms.
So if you've got a diagnosed allergy to eggs, is it still a good idea?
Yeah, so that's definitely a conversation that you'd want to have with your clinician, and it really comes down to if it's the first time receiving it, that's something that they definitely want to be aware of. Egg allergies, they should not be contraindicated, but if there is a history of contraindication, perhaps to other vaccines, this is something that you really want to raise awareness to your family physician, and something to be aware of when you do receive the vaccine.
Person said that they got their flu shot last night at Costco. They weren't charged, so they're wondering if they got the high dose. I would say no.
That's correct.
Correct.
Somebody asked if we can advocate the government to cover the flu shot vaccine. Is CARP working on it? I would say this isn't CARP Calgary's primary advocacy at this time, but it is something that we have talked about and probably look at it for next year's campaign. It's too late for this year. Why is it free down east and not here? I think we just talked about that. Oh yeah, stated the cost of the vaccine varied. Ballpark cost, somebody else said that they were told it would be $80 for the high dose. I think we've heard that before. Any comments from Anybody?
So in our clinic, that we charges about $85. And as I say, we don't charge extra for the cost of the vaccine in which we purchase from Sanofi. But what we did is we charged $25 on top of what we pay for the vaccine purely because the government won't even pay us for administering the vaccine. So we have to add it on the cost. So for our clinic, we charge us about $85, and we have been keeping that steady, for, I would say, a few years now. But I cannot guarantee that is the price in which other places are charging. But for our clinic, that's what we charge.
Okay. And just to not ignore the first question that was asked just after 10 o'clock, I understand that our national CARP fees aren't shared with the local chapters. How do we financially support CARP Alberta? So if you get a new membership through CARP or renew your membership, if you do it through carp.ca, you have to go into chapters and select the Calgary chapter, and then we will get a portion of that. Or when we get in-person events again, we always have a way to sign up where we can get part of that fee charged. Okay, so there are no other questions.
And feel free to email. I'm sure you can get in contact with myself or with Dr. Zabo if you do have any additional questions.
That's correct. Okay. Thank you very much to everybody who participate. And I have booked patient now, so I have to leave the meeting.
Okay.
Bye.
Well, bye.
Thanks very much.
Great. And thank you everyone for attending and for having me and for all your great questions. I really appreciate it. And again, thank you, Doug and Jim.
Thanks, Dr. Millet. That was super. Great information, especially in a time of, worldwide, I'm not going to say panic, but worldwide stress and concern, I think. And the flu season is upon us. And again, more questions and concerns. So thanks a lot for taking your time to talk to us. That's great.
My pleasure. Thank you, everyone. Have a good day.
Thank you. Doug, am I on?
Yeah.
Well, I want to thank the people that have participated and joined us. I think that this is our first event, and we probably have more Zoom events. You need to tell us what type of topics that you'd like, and you can do that through carpcalgary@gmail.com. You can give us feedback on today's session. You can also, if you want to get involved in committees, CARP committees, please send us an email and we'll talk to you. And last but not least, I thank Doug for doing a super job and the team that made this happen. So thank you, and we'll see you next time.
Okay, we'll now end the webinar. Thank you, everybody.